I thought I would start with telling you a little bit about myself. This is my dad. My dad was a military man. He was in the Air Force and an electronics technician, very logical kind of person. This is my mom. She was a school teacher. This is when we were in Japan, and she taught there. And then when we came back to the States, her whole career was teaching children. My mom was a touchy-feely person, and just one of these people that everybody liked. She's a person that talks to you in the grocery store when she doesn't know you. That's my mom. And then, they produced me and my brothers and sisters. I took some characteristics from my dad. So I think that I try to be a lot logical, but I also took his debonair from, and I married her. She's right here. Stand up, baby. Come on, stand up, baby. Come on. She's sitting there doing this. So give her a big round of applause. She's my manager, my CEO, and we're celebrating our 31st wedding anniversary. So, the brother's trying to get some brownie points here, so I appreciate that. And I took some things from my mom. She liked to take care of people. That's me and my baby sister. So I took that from my mom. I grew up in a place called Melbourne, Florida, sister city to Melbourne, Australia. And, in the shadow of the Kennedy Space Center, Disney World. I remember when Disney World opened in Florida. So a place where the sky's the limit and the happiest place on earth, right? Just a nice, idyllic place. But I grew up in the 60s and 70s, and during the 60s and 70s, we had all of the challenges that you may have heard of in the United States in terms of social challenges. And so I lived with this duality of this kind of perfect place, but also the reality of what was going on in my community at the same time. Very similar to where I live now, which is in Philadelphia. Philadelphia is the 5th largest city in the United States. It's a very well-resourced city in a lot of ways. There are more college students in Philadelphia than any place else per capita in the United States. Have major corporations there. Very lovely place. It's a very historic city. It's the birthplace of America. But it's also a place that has the highest poverty rate of any major city in the country. So again, a duality of wealth and resources and challenges simultaneously. And so a lot of my career has been about how do you, in the midst of that, forge out strategies that acknowledge the wealth, but also address the real challenges. This is the man I work for. His name is Jim Kenney. Third mayor that I've worked for. I've worked for 2 governors. I worked in Connecticut for 2 years as a political appointee for 2 governors. Jim is the 3rd mayor that I've worked for. And what he talks about is an effective and efficient government. And I want you to pay attention to the last part of this quote, which is he wants to see a city where people are healthy and well. And that's really what my talk is about, is how do we think as mental health professionals about a well city and what role do we play in that? Is everybody with me? Now, one thing you have to know about me is I'm Baptist, and in the Baptist tradition, people talk back to the speaker. And you really have to talk back to me today. So when I talk to you, I actually want an answer. And if it's a rhetorical question, I will let you know it's rhetorical. Otherwise, answer me, okay? Okay. All right. So, the idea of healthy and well, by the way, how many people in here are mental health, work in the mental health world? Almost everyone. Anyone in here in public health? Just sort of physical health? Okay, physical health. And people are like, what does that mean? Commit, people, commit. Academics? 1 or 2? Okay, few. Okay, great. Clinicians. People are trained as clinicians. Okay. And then how many people are here with lived experience? Okay, great. All right, good. All right, so Jim talks about a healthy and well city, and so particularly since this is a group of people who work in the field, the question that I want you to start thinking about is, what role do you play in that? If Sydney is going to be a well city, mental health plays a role in that, then what role do we play? Okay. Tell you a little bit about my department. I'm in city government, and one of the things that's unusual about my department is typically people like myself who administer systems usually work at the state level or at the county level. I actually work in city government because Philadelphia is both a city and a county. And it's given me a unique perspective as a systems administrator on mental health issues. The reality is, if you were to talk to the police commissioner, fire commissioner, school superintendent, child welfare commissioner, even the library commissioner, they all can tell you how mental health issues affect their work. They all can tell you how mental health issues are often in the top 2 or 3 issues that are drivers in their systems. Talk to the prison commissioner, for example. Jail's full of people who have either mental health challenges or addiction challenges. Police commissioner. And so, in my way of thinking, and I think what we've tried to do in my agency is to look at how do we embed ourselves within government and embed ourselves in these places where people show up needing help. We have a $1.2 billion annual budget. We serve directly about 140,000 people. We have a full risk Medicaid contract, and all that means is that part of my responsibility is also having fiscal responsibility, being given a pot of money, and then having to oversee all of the care for people in the Medicaid program. So we're at financial risk. And I think that's really important because in this talk about a population health approach that I'm going to talk about, it is very much related to the fiscal realities that I also have to deal with. And then children, adults, about 200 providers from hospitals to community-based mental health systems. So the whole point of my talk is to get us to think about a different paradigm for how we think about mental health issues. So here's the premise of my talk. Mental health issues are ubiquitous. They're everywhere. They are complex, and they have a huge impact on our communities. And the current paradigm that we use to address mental health issues is inadequate for that level of complexity. And so I'm going to offer a different paradigm, a different way of thinking about mental health issues. And so in order to do that, I start with what I think is a traditional way of thinking about mental health issues. And I would maintain that it's a black box. That's the mental metaphor that we have. And basically the way it works is this. We create a black box called treatment. People get sick, they come to treatment, we fix them, and they leave well. And that's how we derive the outcomes that we have for people. Wouldn't you agree? You have to say yes or I don't have a presentation. Yes. I can, yes, thank you. I have nowhere to go if you don't buy this. And this is the way most of us are trained, right? How many psychiatrists, psychologists in the room? Okay, social workers, nurses, okay. Most of us are trained to figure out what's wrong with people, treat them, and then we discharge them. And if they don't have something wrong with them, we don't have a role to play. Follow me? Okay? So this is the mental model. Now, it turns out that there are a lot of challenges with this as a mental model for what we do. What are some of the problems with this as the paradigm for treating mental health and addictions?
Waiting until I get sick.
Okay, first problem is we wait, right? It's a passive model that requires people to come to us. What else is wrong with this model? What do we know? I'm sorry, okay, so it's pushing our interventions on the back end when people are in most need of help.
The idea that something is wrong instead of asking what happened.
Okay, so it's not trauma-informed, what I hear under your thing. Absolutely. What else?
We treat them, treat them straight, treat. So we wait for them to get sick and we treat them. Then they come back and get sick.
Okay, all right. So there's not the kind of follow-up, and it assumes that when people leave that they're fixed. Is that an appropriate way to think? No, because mental health and addictions issues are chronic conditions. This is an acute care model. So an acute care model doesn't fit with a chronic condition. What else? Challenge.
You're expecting them to find you.
You're expecting them to find. So this really requires people to know what their problem is, to know how to get to us, to not be impeded by stigma, and that they're going to get to the right box, right? And we know that that can be a challenge sometimes. A couple of more.
Just focused on the person, the people around, and their family aren't.
Okay, I love that. So this is acontextual. You can put this box in Alaska, New Zealand, Sydney, or urban New York. It would work basically the same way. And the reality is that when people are getting better, or when we're trying to help people to be well, that's done in a context. It's done in a family context. It's done in a social context. And often the way we treat people is acontextual. Give me one more. There are actually a lot, and we can't go through all of them, but just give you a sense of what some of the challenges are. Give me one more issue.
Often more of a biomedical approach rather than a biopsychosocial approach.
Okay, right. So this is a more limited approach, often focusing on symptoms and defining success often as eliminating symptoms. Okay, so you can see, and if we had more time, we could go further in deconstructing this model. Let me tell you one of the other major problems I see is that the focus is on the box. Most of the time, for me, my colleagues around the country, we focus so much of our energy on what happens within the treatment setting. And the problem with that is that it constrains how we understand mental health issues, and it constrains the solutions that we see for people. And often it's really interesting watching television programs, and we've had some significant tragedies in the US involving people with mental illness. And almost always the solution is we need more treatment. Now, I'm a treatment guy. I told you I have a $1.2 billion budget. I spend a lot of my time on treatment. But I want to suggest that treatment isn't the only solution to these issues. So we've tried to offer a different model. When we started to move our system, first in Connecticut and then in Philadelphia, to a recovery orientation, we tried to offer a different model. So instead of putting treatment in the middle and trying to figure out how people fit into that, what we wanted clinicians to do and what we wanted program managers to do is to see people in the middle, understand that treatment was one of many things that helps people to get better. And that part of our role is to understand what those other things that are important in people's lives, that give them hope, that give them, help them in terms of their health and wellness, and to work with them and to incorporate them in how we work with people. Most of all, what we wanted our clinicians to do is to view themselves as walking with people through the recovery process. The other point about this is that this is a social, ecological perspective, right? It's seeing people within the context and understanding that if we're going to help people, we should do that understanding what communities people live in. And so one of the things that we did from the very beginning is to not only try to change how we were approaching treatment, making it much more recovery oriented and focus on long-term recovery outcomes, but we also simultaneously started to work in communities because we understood that if we did wonderful work in treatment, discharge people to communities where there weren't supports, where there was discrimination, where there was stigma associated with having a mental health challenge or an addiction, that it would undermine all of our great work in treatment. And so we started very early in trying to reduce stigma, educate people about mental health challenges, worked with faith communities on how they could support their members who had mental health challenges, because we thought that was an important part of helping people create a context for people to get better in. Everybody still with me? Yes. Good, thank you. All right. So if you kind of look at what we've done in Philadelphia, recently I talked to our staff about to put our work in terms of population health in historical context. And it was, this is the way I described it, that we've had basically 3 waves in our history. The first wave was deinstitutionalization, where the emphasis was on getting people out of institutions and into the community. You've probably gone through the same thing and probably are going through the same thing here. The second wave was when we made an intentional move to make our service system recovery oriented. And so the emphasis went from getting people into the community to helping people to be a part of the community. We want people to have a life, have a fulfilling life. The third wave is where we're at now, which is population health. And the reason we got there is that as we were doing the work to try to make communities better for people with behavioral health conditions, mental health and addictions conditions, what we found is that the communities themselves had a whole lot of unmet needs that we as mental health professionals could help with. There were people who had untreated mental health conditions, untreated addiction conditions. There were people who had issues that were subclinical that needed help. And so our emphasis has moved from this idea of just getting people out of institutions into how do we help communities themselves be healthy. The way to think about it is this. This is in the US, the prevalence rate for mental health challenge is about 25%. 5% for people who have serious mental illnesses like schizophrenia, bipolar illness. The way our healthcare system works is that we can only, with the resources that I have, work with people from here up, 25% of the population. And in fact, most of our resources go here in the top 5%, probably 80% of our resources go for those folks. And we basically ignore all of the other 75% of the population. Now, there are a couple of problems with that. One of them is, we talked about it earlier, we have lots of people who are untreated in our communities, but because of the way our healthcare system is set up, these are not people that we can intervene with. And so we miss the opportunity to intervene with people early. Some of these folks who are down here at some point may be above the line, but the way we're organized, we don't work with them. The other issue, the other sort of conceptual piece for us was that if you look at what accounts for our health status, it turns out that health care only accounts for a very small portion of our health status, about 10%, maybe 20% at the most. What really drives how healthy you are, or any of us are things like lifestyle, human biology, environment, the built environment. Those things drive our health care much more than the healthcare system. And but we spend in the US billions, $1 trillion a year on health care, almost ignoring all of the other factors that influence people's health status, okay? So as we have sort of reconceptualized what our role should be, how we should intervene, who we should intervene with, we've really embraced this idea of population health. And population health is just the notion that rather than only focusing on individuals who are sick, our role, as the mayor identified early on, is how do we raise the health status of everyone? And we believe, and I believe very strongly, that by doing that, we actually serve people who are at the top end of that pyramid a lot better, because we have more opportunities to intervene with them. We have more opportunities to create an environment in which people can get well and stay well. So if you sort of reconceptualize the population and thought of people as being those who have a diagnosis, those who are at risk, those who are healthy, a population health approach looks like this. For people who are the sickest, the people who have the diagnosis, that our role should be, how do we create an effective and efficient clinical system So in population health, it's not this notion that we're moving away from treating people who have the most serious forms. In fact, in a population health approach, you have to bring your A game, right? You have to have really good services, because if we're really good at intervening early, we want people to go into the best possible clinical services. So first thing is that it's really important in a population health approach to have excellent clinical services. I'm going to talk a little bit about how we've tried to do that. Secondly, we know the people in our communities who are at higher risk for having a mental health challenge. Who are some of the folks who are at greater risk for having a mental health challenge in our communities? I'm sorry? Okay, people who are homeless? Absolutely. Who else?
Drug and alcohol.
Okay, so if you have an addiction, much more. Who else? I'm sorry? Veterans, absolutely. People who have experienced trauma. Who else? Yes, yes, absolutely. Occupations that have high stress. Give me a couple more. Adolescents. I'm sorry. Disabilities. Being unemployed, right? So, prisons, right? Absolutely. All of those are. So we know who the people are in our community who are at risk. The question is, what are we doing? And so in a population health approach, what we are trying to do is to mitigate risk to the extent that we can, if we can reduce the risk. But if we can't, how do we intervene at the earliest possible moment? Because everyone in this room, because most of you raised your hands when I asked about people who worked in the field, you know there are many, many people that are coming to us way too late in the process, right? And so the issue is, how do we get to those people earlier? And then here's the big one. How do we help people who are healthy stay healthy? Something we don't get trained in, and certainly I didn't. Maybe you do in Australia. But in the US, we don't train people on how to keep people healthy, because we're all the way up at the top of the pyramid working on only on those folks who are ill. And so that's what a population health approach looks like. So the rest of my presentation is this. What I want to do is just give you some examples of how we've tried to move to a population health approach in Philadelphia, and talk about what some of the underlying concepts and principles are. So I mentioned that the top of the pyramid was, how do we create excellent clinical care? For that, there are several strategies that we've taken. The first and most important is to work from a recovery framework. That we've been very intentional about saying that our role is not just to do symptom management, but to really help people on a path of long-term recovery, to include evidence-based practices, individualized treatment, and to make sure that we have the kind of recovery supports that people need to be successful. So one of the major strategies that we've employed is to try to systematically infuse EBPs in our system. And the rationale being this: if we really want to help people to recover, we ought to know what the science says about what works. And we should make sure that we're systematically implementing that. So these are some of the people that we've worked with. We had the good fortune to work with some of the creators of many of the EBPs. Over time, we've trained hundreds of therapists, programs. And one of the great things about working with the creators of EBPs is that we get to toy with them in ways that we might not otherwise. And so, for example, in some of the work that we've done with Aaron Beck, we've taken cognitive therapy, cognitive behavioral therapy, implemented it in settings for which it had not necessarily been tested from a recovery orientation, and been able to improve treatment outcomes. One of the programs where we've done that is working with people who have very serious illnesses, who are literally stuck on inpatient units for weeks, sometimes months at a time, and been able to improve outcomes by doing that. These are just some of the EBPs that we've done. We try to use every possible lever to improve treatment outcomes. So one of them is to use data, and the most powerful, you know what the most powerful strategy for improving services is? I know you all know this. What do you think motivates our provider system more than anything else. What did you say? Cash. There you go. Right. So we have a pay-for-performance system, and I just want to give you an example of how we've tried to use data and cash to improve treatment. So this is retention and programs, and the blue line, if you just take kids who are in ASD programs, who are on the autism spectrum. When we started, we had 63% of the kids were not being retained in treatment. That's a lot of kids that were dropping out after only 2. Once we introduced financial incentives, you can see, and this is early data, this goes back, I think, to 2013, these numbers have continued to improve. We had dramatic decreases in the kids who were dropping out and increases in the kids who were being retained. My point is that what we're trying to do is to use every lever that we have, whether it's training, whether it's data, whether it's finance, to try to improve treatment. So let me move to, I'm going to skip that for now, this idea of population health. And so one of the things that's really important to know is when you're dealing with a trend or a fad. So some people may say, well, you know, this population health stuff is just the flavor of the month. People also said that about recovery, by the way, when the recovery movement started, and they miss. Let me tell you really quickly why I don't think that population health is a fad, and it has to do with cash. It has to do with how we finance services. At least in the U.S., one of the big challenges that we have is that the healthcare costs are growing up at a very high rate. That's why we have healthcare reform. And in fact, the healthcare inflation is about twice that of the rest of the population. It's untenable. And so the way that healthcare systems and healthcare payers like myself are thinking now is how do we create financing mechanisms that incentivize people to get people better quickly and to keep people better and to keep people well. And so increasingly, I mentioned that we're at financial risk. Provider systems are going to be put at financial risk because that's really the way to do it. And so once provider systems are put at risk for a population of people, there are tremendous incentives then to keep people well and to intervene at the earliest possible moment. So let me quickly just go through the 7 shifts that I think are going to be necessary for us as a field, the mental health field, to shift from the black box paradigm that most of us were trained under to more of a population health way of thinking. So the first conceptual shift is thinking about how do we move further upstream in terms of how we work with people. We mentioned that the black box is passive. It waits for people to be at the late stages of their illness. The issue for us is how do we get upstream? One of the ways that we do it is, and I'm giving examples of all of these. So this example is with the issue of trauma. And we know that people with untreated trauma are coming into our treatment programs very late in the process. So one of the things that we're doing is trying to reach out to people in the immediate aftermath of traumatic events. Unfortunately, one of the things that happens in urban settings is that you have people who are killed or injured through gun violence or other kinds of things. They're usually vigils. What we do is we train people in psychological first aid to go into communities in the immediate aftermath of these kinds of events. And what they're doing is they're trying to, one, support people during a difficult situation, but also educate people about what a normal trauma response is, what's an atypical response, and then how to get help if you need it, what kind of resources. So it's a way of signaling to people that these are traumatic events, that they have an impact on you, and that if you're having difficulty, here's how you get help. And we do this not only for these kinds of events, but we've had building collapses, we've had accidents, we had train derailments, we had all kinds of events that happen in communities where people are traumatized. And unfortunately, what had happened historically is that we tell people, just get over it. And sometimes that works, but sometimes it doesn't. Another way that we're trying to do this is, this is a great example of how evidence-based practices and attention to clinical work really meshes with this population health approach. We know how many of you are familiar with the ACEs study? Familiar? A few? Okay. So the quick story on this is that researchers looked at adverse childhood events that happen in a fairly middle class, it's actually very middle class population, California, Kaiser Permanente. And basically what they found was this: the more adverse events that children had and people had in childhood, the greater the likelihood that they had all kinds of physical problems and mental health problems and social problems. And so that research has been really important in helping us understand that it's really important to intervene as early as possible with people in general, but children in particular. So one of the things we do is we screen children in lots of different pediatric settings, primary care settings, and pediatric mental health settings. We also created a network of about 16 providers who are trained in trauma-focused CBT, evidence-based trauma treatment. What happens is those kids get screened. If they're identified, there is a provider in almost every part of the city to whom they can be referred for help. So over the last few years, we've screened about 10,000 children in these pediatric settings and are connecting them, those who are coming up positive to get further assessment and treatment. So again, it's trying to get further upstream. And there are several other kind of strategies, and we can talk about that during the Q&A if you want to. Secondly, to make this shift, I think it's going to be important to move beyond what we've traditionally used as our tools. So primarily what we do in our field is psychotherapy and medication, maybe case management. Those are the primary ways that we intervene with people. The reality is, as highly trained professionals, people who've gone to graduate school, gotten their training, there's more things that we can do. We can train people, we can do consultation, we can help people build capacity. I'll just give you a couple of examples of how we are trying to broaden the way we think about how we intervene. And I'll start with mental health first aid, which everyone in this room should know. It is one of the great gifts of Australia, in my humble opinion. You guys given the world a lot of important things, but in my opinion, mental health first aid is right up there with all of those. I am the biggest fan of mental health first aid on the planet. And the reason is I've not seen anything that has had the impact in terms of reducing stigma than mental health first aid. We have a very aggressive strategy of trying to train as many people in mental health first aid as we have trained in CPR in our city. That's our goal. And so we're going to try to get to 10% of the population. This year we'll probably reach 20,000 people, but we're going to try to get to 10% of the population. And so that no matter where you go, if you're in a restaurant, someone has a heart attack, someone knows CPR, right? If you're in a restaurant, someone says, I want to kill myself, everyone goes the other way, right? And so we want as many people in our communities trained in mental health first aid to provide support and to be have that literacy. And so we're doing it across every conceivable sector of our communities. Our police all get mental health first aid trained, as well as something called crisis intervention training, which is a whole week-long training. Our paramedics, healthcare, we have a whole strategy with our faith community, with Jewish, Muslim, Christian faith, just a whole wide range of people. We even do it with our American Red Cross. So we have a partnership so that when you get trained in CPR, you can also get trained in mental health first aid. So it's mental health first aid as well as physical first aid. And I wanted to show you this data because this is a great example of how I think increasingly we can think about policy and how policy shifts how policy can make a big difference in people's mental wellness. So in Philadelphia, we have lots of children, and if you look at 2006, we had almost 2,000 children in residential care, and we had over 300 that were in out-of-state. So these were kids, many of whom had been abused, neglected, child welfare system, sent literally 1,000 miles away, 2,000 miles away to treatment programs. Everyone in this room knows that that's not good policy. The way we were able to drive these numbers down, today we have maybe 10 children out of state in Philadelphia, and we're down to about 400, a little over 400 people, kids in residential care. The state is kind of old. But the way we were able to do that, a couple of things. One is we changed the policy. Myself, the child welfare commissioner, and the family court judge, we decided, look, this is bad policy for children. We're not doing them any service. So that started with that. But then we did the training. We trained the judges. We educated the judges. You don't train judges. Sorry, just in case there's judges watching this. We were corrected about that. So we educated the judges about what was really in the best interest of children. They thought they were doing the right thing, but they really weren't. And so, again, thinking about how do we use policy, how do we educate people so that we get better outcomes. Working with non-diagnosed populations. We're very comfortable working with people who have a diagnosis. This is Burmese and Bhutanese communities. I have a saying that is inherent in every community is a wisdom to solve its own problems. And one of the challenges we have, and you know, just riding around Sydney in the last day, it's a very culturally diverse community. So without knowing anything else other than what I've observed, you have to have communities that are not accessing services at the rates that you would expect given their numbers in the population. I just know that, right? Am I right? Yep. Okay. So the issue then is we know that the typical ways that we've approached that are not going to work because it's a black box waiting for people to come. So we go to these communities and we say, okay, you define the problem. What are the issues that you want to work on? And for many communities, it's often trauma because they're coming from difficult communities. You define what you think the solution is. And then we'll work with you. We'll fund you to implement those. And so with the Burmese and Bhutanese community, and again, I'm using this as an example. We've done this with multiple immigrant groups. They said, look, you know, the best way for us to work with people in our community is we want to create a storefront. And that storefront is going to be an all generic kind of place where people can come for immigration help, ESL, English as a second language help, those kinds of things. And one of the things that we required is that they do this in a coalition with a mental health agency, a healthcare agency, faith agency, indigenous helper agency. When people get identified as having mental health challenges, they get connected to services, or there's an intervention within the context of that group. So we're reaching a whole different population that we would never reach if we were to simply wait for them to show up at our traditional treatment programs. Delivering health promotion interventions. One of the ways we're doing this is we created a website called healthymindsphilly.org, and you can go to it if you're interested. But what we did was we created a website. You may notice it doesn't look like a government website. You know why? Because we wanted people to use it. So we made it intentionally not look like a government website. But what we do is we put a lot of information about wellness and things that are happening in the community. So we want it to be a place where people are thinking of, this is a go-to place for wellness things. We also have our screening initiative. So you heard John talk about the screening initiative. It started with an online screening tool. And the screening tool takes about 10, 15 minutes for people to go on. They can screen for depression, PTSD, a number of things. John mentioned that we do that in the community now, getting a checkup from the neck up. And the really interesting thing is that people said people will never come up to you in Philadelphia and publicly come up to a table that's about mental health issues And we found just the opposite. People are very hungry for this information. And as John said, invariably, there's at least one person who's suicidal. And it makes me wonder, what if we weren't there that day? And it also makes me wonder, who else is in our community who might be suicidal and they have no idea of where to go. And so it reinforces for us the importance of us being outside of that black box and being in the community. And one of the things that I really like, I have great staff. We put a diverse group of people out, people who speak different languages. We put people, part of the team are people with lived experience, part of the team are clinicians. We have protocols set up with our crisis centers if someone needs help. And they're really excellent at getting people to come over and get. And this just shows you, again, the interest. These are the number of screenings that we've done that have happened online. We'll be well over 5,000 for this year, and starting with a few hundred. So the word is getting around, and people are starting to see this as a resource. Working in non-treatment settings. One of the things that I think is really important is how do we deal with social determinants. Biggest one, at least in my experience, is the issue of housing. So I'm going to give you an example of how we've tried to use this particular determinant to improve overall health status. So we have a significant problem with homelessness in Philadelphia, as most major centers in the United States do. We actually have the lowest street homeless rate in the country of the major cities, in part because even before I came to the city had set up these mechanisms for this. So what we've done more recently, though, is to try to create multiple pathways from the street into permanent housing. And by the way, do you know what the best solution to homelessness is? Yeah, there you go, housing, yes. So in the US, people say, oh, you closed all the institutions and now we have homelessness. And I say, no, we have homelessness because these people don't have a place to live. And that's a really important distinction. If you're interested in some of this is like some of the pathways we created, but Housing First is one of the pathways. We've also created a program called Journey of Hope for people who have very serious addictions, because what we found is that people who have addictions, the Housing First model doesn't work quite the same way for someone who has a very serious addiction, so we've created other programs for that, and I can talk about that if you know. But in addition to getting people into housing, I want to just share with you some of the financial data, because this is a great example of win-win-win. When the last mayor came into office, one of the things he negotiated were housing vouchers with the housing authority in Philadelphia. We leveraged those housing vouchers with Medicaid dollars, which are basically treatment dollars. And basically what we found was that these are different cohorts of people that came in. Some people came in through these programs called Safe Haven, some came through Journey of Hope, some came through other mechanisms. But 2 years out, the folks who came in through this setting, they were costing us $85 a day. Now, I was thinking erroneously, that people who are homeless are not costing us much, and that all of the costs associated with this program were actually going to be added costs. Well, it turns out that's not true. They were going to crisis services, lots of other services. So 2 years out, $85. We engage people, and you can see the cost going up. So as we engage people, the cost actually went way up to $112. But then look what happens once people get into housing. The cost went down to $18 a day. So a huge savings. I mean, we've saved literally millions of dollars just by leveraging our treatment dollars with housing dollars. We've done that with this program as well, just in terms of the decrease in cost. So this is a win-win. We get people off of the streets. We've gotten over 1,000 people who are street homeless off of the streets using this strategy. But it's also been a cost savings to our system. And for the housing authority, they love it, because what we're committing to is these people aren't just going to go into housing, but they're going to go into housing with supports following them. So it's a win-win-win. And here's just We like baseball in the U.S., so he's a Phillies fan. So, health activation and empowerment. One of the challenges we have, in addition to immigrant groups, which often don't come into treatment, we have subpopulations in the U.S., one of them being males, and particularly males of color, African American males, Latino, and Asian males. And so we did an initiative specifically to reach out to that group. And the way we did it, though, was we didn't want to go to those communities and have a conversation about mental illness and psychopathology. We went to them, we said, we want to have conversations with you about mental wellness and mental strength. And so we actually worked with a communications firm, worked with an arts organization called First Person Arts, run by a woman named Jamie Brunson, who is brilliant. But here's this arts organization. They do storytelling events, actually have a festival each year. And so we started working with them. We said, like, what if we started to work together and did programs, storytelling events, focused on men's mental wellness? And that's what we started to do. And here's some of the people. So what we would do is we'd send out a call for proposals. Guys, men would volunteer to come in, to be a part of it, to tell their story. And usually, we have all kinds of stories. People had seen their mothers abused and sort of were dealing with that. Some who had trauma themselves. Some who were depressed. I mean, all kinds of issues that people had. They work with professionals to tell their story. We get a famous person. So I don't know if you've heard of a program called Empire. Is that show here? Okay. All right. Yeah. So I don't watch that program. Okay. This didn't work in New Zealand. It's not working here. There's a cultural issue here, right? So anyway, it's one of those shows that, highbrow people would never watch, right? But anyway, no, I actually like the show. But he's like one of the lead actors. This guy is a guy named Black Thought. Does Jimmy Fallon? Okay, so the band, The Roots, he's the lead singer. So he's from Philadelphia. He's one of the, so each time we would get a famous person, here he is, Black Thought, probably looks familiar, along with these guys from the community, tell their stories. First time we did it, we got like 300 people on a Friday night. It's like, wow, talking about men's mental health, right? Because what we would do is they would tell their stories, and then we would have a talk back session, 30 minutes or so, and the whole conversation would be about what can you do about your own mental health? What kinds of things can you do? And turns out that all of these people, and we didn't know this when we asked them. We just asked them because they were famous and they were from Philadelphia and they would actually get people to come to our event. But all of them had these stories. This gentleman is a very famous actor now in the U.S. He had been involuntarily committed 4 times, and we didn't know that when we invited him. And so he told that story about being involuntarily committed. He had serious mental health issues himself. So it's been really interesting. We had 600 people the next time that we did it. We had 1,000 people the next time we did it, and these were with youth. And so we're getting these conversations with people that we would just normally not do it. The last example that I want to show you is, so the last one was about sort of reframing from just thinking about psychopathology to thinking about how do we help people take more ownership over their own mental health. Last strategy that we're trying to employ is working not just at the individual level with the person that comes to see us, but how do we do community level interventions? The only way we can get there on population health is to have community level interventions. We've got 1.5 million, you have 4 or 5 million people here. You're not going to get there trying to do it individually. So what are the things we can do at a community level? So if you come to Philadelphia, you will see very quickly a mural. The city has more murals than any place in the world. The murals are actually painted by the community. And what happens is, and I heard the leader of the city's mural arts program, a woman named Jane Golden, again, just phenomenal person. So Jane described early on in my tenure as commissioner, how they did these. She said, look, we go into communities, we bring people together, we get people to talk about a particular topic. An artist works with the community to design the mural, actually sketches it out on what's called parachute cloth. That's what they're painting on. And he does a paint by number. So you remember the old coloring books we had? So it's actually paint by number. The community comes in and actually paints it. So I was like, wow, you know, and at the time we were thinking about this issue of how do we try to reduce stigma in our communities? How can we engage people around these kinds of very difficult conversations? So I said, hey, Jane, you'd be interested in working with us around topics related to mental health? She was. And so it started a partnership that's gone on to this day. I started with a little bit of money. We've gotten probably at this point about 10 different foundations that have supported this work. And we've done all kinds of topics. This is in the Southeast Asian community. This is what it looks like today. This one's on gambling. And the reason that this one's on gambling is because the Southeast Asian community said, you know, this is a big problem, mental health problem in our community. We have lots of people who have gambling addiction. And we want to focus on that issue. So there are a whole series of conversations and workshops. They came up with the concept, they painted it. This one is in the West African community. A lot of trauma from that community. They were having difficulties, challenges with the youth, were having challenges with American youth. And so they did this project around bridging the gap between those two communities. This one is on trauma and violence, focus on children and the trauma that they experience. This one is in the Latino community, and it's about conversations that people had around how do we build resilient communities in the Latino community. This one is connected to that Engaging Males of Color initiative that I talked about a little earlier when I was talking about the storytelling event. We also did murals. You can't see embedded in that, but there are depictions from all of the 3 cultural groups. So you'll see imagery in that mural from the Asian community, from the African American community, from the Latino community, all sort of the meaning in there. This is one of my favorite. This is one on suicide. We had 1,000 people to work on this mural over the course of a year. There were workshops, there were lectures, there were a whole series of things leading up to the design and then ultimately the painting of it. You can see down here, these are portraits of people who died by suicide. We had a rash of suicides by firemen, and so a lot of their families and their buddies, firemen, they came and they actually helped to paint this particular mural. But it opened up a whole conversation that we would not ordinarily have. This one is one in part of the city where next to, well, this building is actually houses a methadone clinic. Do you all use methadone treatment here? Okay. A lot of stigma associated with that. Communities don't want them. And the community really didn't want this program there. If you look at this painting or this picture, can you tell who the people are who are the methadone clients, right? Versus the neighbors, right? You can't, right? And so one of the things we know from the stereotype literature is that one of the ways to reduce stereotypes is to have close social contact, right? And so communities kind of come together working with that. This is the way it looks today. It's a 5-story mural. And the dynamic between that provider and the community changed because of this work, where on the other side of this building is a community garden that was done jointly with the provider and the program. So it really changed the dynamic. So the point is that we've done these all over the city. We have probably about 25, 27 of these murals. If you're interested, you can go to our website. You can take a virtual tour. I've given you just a snapshot, but you can hear more in depth, see or read more in depth stories about the different murals that we've done. There was an evaluation done by Yale University that basically showed what we thought these murals would do, which is that that it had both an individual level effect in terms of the people working on it. But here's the cool thing. Even people who don't work on these murals have a benefit. And so what happens is once these murals are done in communities, you see increases in perceptions of social cohesion in those communities. which we also know is related to people's health status, right? So this is, again, a community level intervention that we are employing. So let me just kind of summarize what I've tried to talk about today. So what I've said is that I believe that mental health issues, addictions issues, are complex and ubiquitous, and that the current paradigm doesn't really match up to that we need a different way of thinking about these issues. What I've tried to offer is the idea that a population health approach, where we're really trying to improve the population, the mental health status of everyone in our communities, actually helps us to get there. And in addition to providing excellent clinical care, here are 7 things that we believe and that we're trying to do to shift how we approach it. Working further upstream, increasing the set of things that we do as professionals, working with people who are not necessarily diagnosed, thinking about health promotion and how we help people to promote mental wellness, working in settings that we may not be comfortable with, out in community settings, helping people to take ownership over their own health status, and having these community level interventions. So that's my story, and I'm sticking to it. All right. But before I end, I just want to leave you with this idea. So one of the questions I get asked a lot is, does all of this stuff make any difference? And I just want to give you one piece of data, so to speak. Our first recovery walk in Philadelphia, this is actually before I got there, had about 150 people at the first recovery walk. Last year, we had 25,000 people at our recovery walk. It's done by one of the recovery advocacy organizations called Proact in the city. I believe that we are beginning to change public attitudes about these issues. We're getting more people engaged, people we've never engaged around these issues. Ultimately, I mentioned that, I have this very significant financial responsibility. I have an $800 million full risk contract. And I'm, spending my time thinking about murals. And the reason is because I think that those kinds of things actually not only help the community, but they help me manage my budget a lot better because we're getting to people earlier. So I think this is an important process. And I want to end with where I started with my family. And this is my grandma. I love my grandma. If there was a picture of an angel in the dictionary, my grandma would be there. That's how I think about my grandma. And she helped raise us. This is actually a picture of us in Japan, because she went all around the world with us. And my grandmother had a 2nd grade education. When most of her life, she was legally a 2nd-class citizen in the United States by law. I mean, there were places she couldn't go, things she couldn't do by law. Her grandmother had been enslaved. She was born in the 1800s. And so the United States was just not long out of slavery, and her grandmother had actually been enslaved. I live in a world that is absolutely unimaginable to my grandma, right? We have an African-American president in the United States. She has a grandson who manages a $1 billion agency that has hundreds of employees who are from all kinds of backgrounds, and who gets to come to neat places like Australia to talk about the work that we're doing. So it's an unimaginable world. And so I just want to leave you with this, that I do believe that we can make this change to think about our issues differently. I hope I've given you some ideas that kind of pricked your thinking. I know there are a lot of very exciting things that are happening in Australia. I think some of the work that you all have done in lots of areas, whether it's mental health first aid, I know that you've been at the forefront of a lot of the recovery work. I think that there is an opportunity for us to build, or for you all to build on that. Again, I hope that I've shared some things that might stimulate your thinking around that. So, thank you.
Look, Look, I think Arthur was an exceptional speaker who really spoke to a lot of the challenges that we face globally in terms of mental health in our cities. I think part of what their prescription is in Philadelphia of treating the health of the whole community is so important for what we're doing here in New South Wales and what we need to do, and making sure that it isn't just a case where we're treating people with trauma, but making sure that everyone in our community is healthy, and making sure that we look at people at the earliest stage of their own wellness and that path to recovery and to being full and active participants in our community.